So I just want to point out that I followed Lisa's instructions, and I kept this very short and not a lot of bells and whistles, but it's easy because I'm right. Here are my disclosures. None of them are relevant. So as somebody who has done, my training and then a large part of my practice, extracorporeal anastomosis, and then changed to doing intracorporeal, I can tell you with my own experience the dramatic changes that I see. One of the biggest benefits for ICA for rights is that you require less manipulation of the bowel, less dissection, and you don't need to put any tension on it when you're exteriorizing for your anastomosis. This does lead to less ileus, there's less blood loss, and also very importantly for those of you who are doing extracorporeal anastomosis, you can never, or you should never be able to twist your anastomosis if you're doing things intracorporeal. And it allows for your fan and seal extraction often through the smallest port. And I like to use a 12 millimeter port in the suprapubic area for my stapler anyway when I'm laparoscopic or robotic, and then that's what I'm going to upsize for my extraction. So all of my other ports are not going to need to have any sutures in them for closure, and that also decreases pain. So less pain, less narcotics, there's going to be less surgical site incidences and infections, and definitely down the line, less hernia. For lefts, ICA, and if you add natural orifice extraction, again, less manipulation of the bowel. You don't have to try to pull that thing out through the fan and seal incision or someplace else and wonder whether or not you have enough length on the bowel to get your anvil in, or if you're tearing mesentery. And if you do natural orifice extraction, you're avoiding that incision altogether. There's just no other way to quantify that other than there's less pain and then the other things associated with it if you're avoiding that larger incision. And this converts basically your MIS incisions from your standard colectomy to basically like a lap chole. And we send those people home in the same day. And it's more cosmetic, which leads to happier patients. And whether or not that's something that you can validate, I think that patients do identify the size of their incisions with whether or not they had minimally invasive or maximally invasive surgery. And the happier they are with that, I think that it lends itself to faster recovery. And I'm just going to leave these pictures here as a demonstration. This is both 2 weeks post-op. The picture on the left was a secondary ileocolic in a young man with Crohn's disease that I did a fan and seal extraction through that 12 millimeter port, and the one on the right was a sigmoid resection. And nowadays, avoiding even using staplers, I don't even have a 12 millimeter port, so there's no transfascial sutures in that right lower quadrant port, which is often the one that patients hate the most. And eliminating that altogether eliminates the pain, and the majority of my patients go home on 0 narcotics on day 0.
Outstanding. All right, Pat, take the con, or the mini con.
Right. Sylla. So I'm going to start by saying I cannot argue against ICA. There's absolutely no way you can object to the fact that intracorporeal anastomosis is better than extracorporeal for right-sided. We're already doing it for left-sided. My slides, please, would be nice. Sylla. Yeah.
There we go.
Very good. These are my disclosures, which are not moving.
The green button.
Yeah, I know what the green button is.
An advanced slide.
This is starting well, just like in good old days in the OR. And my disclosure slides here, none of them are relevant to this talk. So I have absolutely no objection to the fact that ICA is critical in terms of what really makes a big difference when you're contemplating moving towards same-day colectomy. MIS technique is a slam dunk, whether it's lap, robot, or hand assist, or a hybrid technique, doesn't matter. The smaller the incision and the less manipulation, the better. And then I think the controversial part is really extraction site, and I'll talk about that. I object to nose, and I'll explain to you why. And then the extraction site, midline versus off midline, fan and steel, although theoretically it makes a lot of sense, there's not a whole lot of data to support that, and we need data. That's the bottom line. So listen, I'm the biggest nose, you know me and my track record. I've been doing this for 10 years for rectal cancer. It is hard, okay, my friend. Learning curve is really high, but I believe in it. But it's only feasible in a part of the patients. About 60% of patients with rectal cancer, you can actually do a transanal extraction of the specimen. Lisa knows that very well. Because the tumors are bulky, there's always a problem of fracturing the specimen. And then, the pelvis can be very narrow in males. So it's technically very challenging, especially to put them back together. So for benign disease, yes, it's less stressful, but it's still, you're going to be dealing with very big specimens. This is my last diverticulitis case. I can't imagine pulling this through a healthy rectum. So there's a risk of spillage when you have an open rectal stump. It really adds complexity to the case. So you really have to think whether or not it's even worth it, okay? And if anything goes wrong with your purse string, when you're putting your distal purse string, you're going to have a major catastrophe and you're going to be totally turned off from the whole thing. So just be careful. Also, you're going to have longer time. You need somebody to go to the bottom and help you extract. So that adds, additional personnel, et cetera, et cetera. So I think we need to really flush out who are the best candidates if you're going to be doing this, because you're going to have to be pretty selective. But extraction, I think extraction is quite controversial because we know that extraction sites matter in terms of incisional hernia. We know that fine and steel incisions, based on this randomized controlled trial by Larry Lee himself, shows that actually it's associated with less risk of incisional hernia. But when it comes to pain, we don't have a whole lot of good data. Okay, there's really no randomized controlled trials in colorectal or even GYN. And then this is the only decent study that I found where they actually retrospectively looked at a series of robotic colorectal resections. You can see the majority of those patients were getting ICAs, but they looked specifically at using fine and steel versus midline versus off midline. And of course, it's not perfectly matched. This is not a perfect study from a rigorous scientific design, but they really could not demonstrate in the setting of using epidurals, tab blocks, all the things that we're using for enhanced recovery protocol. They could not find any difference in terms of pain score for those patients. So it's not quite clear what really matters, if it's more the perioperative anesthesia protocols and tab blocks and all the things that we're doing that we know really work, or it's really truly the extraction site. So the verdict is still out. Lisa, I'm sorry to say. Thank you.